on behalf of my whole Ratlam Society, take the pleasure of welcoming all to our webinar today. Today is a great day as 7th October is marked as National Poetry Day, International Day of Non-Violence, and today is also an auspicious day because Navratris have started. So with all the boom bang of this festival season, we start our webinar, for which I invite our President, Dr. Manisha Maheshwari ma'am, for the welcome note.
Thank you, Dr. Neha. Good evening and namaskar. I am delighted today to welcome our guest faculty, immediate past FOXI Secretary General Dr. Jaydeep sir. We all know him as humble, easily approachable, hard-working, dedicated and taskmaster of FOXI. I warmly welcome Dr. Pratik Tambe sir, another star of FOXI with great repute. I extend hearty welcome to our own Dr. Asha Bakshi madam, pride of MP, to chair the session. She is Vice President-elect 2022 West Zone FOXI and Organizing Chairperson of AICOG 2022. I also welcome Dr. Nilesh Dalal sir from Indore, great academician, professor and head of the department OBGYN, MGM Medical College, MVA Hospital, Indore. Today's meeting is studded with stars of FOXI and I am sure all delegates will have a great learning session. Endometriosis and Challenges in Management. I welcome all the members of Ratlam and other societies who have logged in with us. Now I take the opportunity to introduce Dr. Nilesh Dalal sir, chairperson of our first session. Neha, please sir ka CV laga do. I take the opportunity to introduce him. He is Professor HOD Obs-Gynae Department, MGM Medical College, MVA Hospital, Indore. Immediate past President of Indore Society. He has 28 years of UG/PG teaching experience, gold medalist throughout MBBS. National faculty at all AICOG have been awarded many prizes and long list goes on. I welcome sir and kindly introduce Dr. Pratik Tambe sir, our guest speaker.
Good evening everyone. Thanks Manisha, one of my favorite student.
Thank you.
And Dr. Neha Shah, very active member of Ratlam Society and gearing up very well for all academic activities. The society is doing really good. I should congratulate all of you. And many times Manisha asked me getting into as a chairperson and speaker, but because of the government issues and all, you know very well, going on from morning till night. And I said, no, this time an auspicious day and slightly a lighter work because of Navratri. We have Dr. Pratik Tambe, whom we have met many times, and we had talked together also at Jabalpur on pregnancy-induced hypertension and on preterm labor if 2-3 times. And Jaideep is there. We all since decades know each other. It's more like a family meeting, I should say. Ratlam and Indore Gynae Society with all FOXI members, senior members also. We may have the slide, Neha, of Dr. Pratik. I know Pratik very well and he's an academician, rather getting onto the slides also, but I know so many awards he has won from Mumbai Obstetric Gynae Society, even from the FOXI on different platforms of academic. And he's contributed chapters. My slide also, it couldn't come and maybe this slide.
I'll just share my screen, sir. That will make everybody's job easy. I think that should be
okay.
Short, sweet, and simple.
Okay, so short and sweet. Chairperson of MOX Endocrine Committee 2022, Governing Council member of ICOG 2122, Executive Committee member of ISAR 2022, Managing Committee member of MSR 2122. In these 2-3 years, he is in so many committees and chairperson also. Chairperson of FOXI Endocrine Committee, important this post in FOXI in 17 to 19, and Managing Council member of Mumbai Obstetric Gynae Society. I welcome Pratik Tambe to speak on an important aspect of endometriosis, challenges and dilemmas in adolescent group. Pratik, please.
Thank you very much, sir, for that kind introduction. Let me begin by offering my gratitude to the Club Society office bearers, the President, Dr. Manisha Maheshwari, the Secretary, Dr. Niyasara. My greetings to Dr. Asha Bakshi, ma'am. Thank you so much for being here, and of course, to Dr. Nilesh Dalal. Actually, I was wondering whether Dr. Jaideep should go first, since he is the senior person, and sir is already logged in. If that is okay with him, I will proceed. Otherwise, sir can go first. Right, he seems to have stepped away from the desk. So I'm here to talk to you about adolescent endometriosis, challenges and dilemmas. This is going to be a short and sweet presentation for about 20-25 minutes. And whenever we talk about endometriosis, I'm reminded of this quotation from maybe a couple of centuries ago, where Alexander Dumas said, "The merit of all things lies in their difficulty." I'm sure all of you will agree that diagnosing endometriosis at an early stage, stage 1, 2, where it is amenable to medical management, where surgery is not really indicated, and where the long-term outcome is always going to be better in terms of pain suppression as well as preservation of fertility potential, is something of a challenge for all of us in today's world. I've tried to structure today's presentation in the following format. We look at the current scientific evidence, guidelines from international bodies. We talk a little bit about the FOXY protocols for practice. We'll try and talk about the management more, and here we'll focus on the medical management versus the surgical approach. And finally, the rationale behind medical management for adolescent age group. If we have time, we'll talk a little bit about the role of counseling and the concept of fertility preservation, which is all important in today's life. So there's a surfeit of evidence as far as endometriosis is concerned. We have guidelines. There are also ESHRE guidelines, which are going to be updated any day now. We're just waiting for the update to come in. There are also guidelines which have been published by FOXY. This is the FOXY GCPI, which was last published in 2017, if I'm not mistaken, when Dr. Alka Kripalani was the president of FOXY. We also had a systematic review of various national as well as international guidelines. It's published in the British Journal. And this is the most recent NICE guideline published in 2017. And finally, this is the FOXY Vision Endometriosis Protocols for Practice, which we did a couple of years back in 2019. This was released at Hyderabad at the hands of our president, Dr. Nandita Palshet, who was then president. So you can see Professor J. Turandare and the current president, Dr. Shanta Kumari, also there in the picture. So let's come to what is the actual evidence and what are the recommendations as far as endometriosis is concerned. We've been taught that endometriosis classically presents as a triad, and that is dysmenorrhea, infertility, and dyspareunia. When we are talking about adolescent endometriosis, two of these obviously do not apply. There's no question of infertility in an adolescent girl because she's unmarried, and obviously dyspareunia is not something which you be able to elicit a history of in most adolescents in India. What is of importance here and clinical relevance is that we have to understand that endometriosis is something which we are diagnosing more and more at a younger age and with greater frequency in today's world. Firstly, probably because patients are presenting to us early. Secondly, maybe the pain threshold of the newer generations is much newer as compared to 20-30 years ago. And lastly, I think it is of paramount importance to understand that the incidence of the disease per se is on the rise. Finally, it is of also great importance to understand that endometriosis is something which we diagnose at the end. It's a diagnosis of exclusion. Don't always think of endometriosis first, because like a good student, we always think of the rarer causes first and common things later. But in practice, it is the other way around. People who do very well in medical college exams and score gold medals and distinctions, in clinical practice, they may often find that the duffer student who studied only for 2 days before the exam and talked about common clinical conditions is the one who does well in clinical practice. Similarly, endometriosis should be a diagnosis of exclusion. Think first of the various other things which have been listed out in this particular table. For reasons of paucity of time, obviously I will not be able to talk about each of these, but this is the take-home message on this one simple slide, that think of endometriosis last, though the incidence is increasing. How do we as clinicians screen our patients in our busy practice? If you have 20, 30 patients sitting outside, which you need to see in, say, maybe 1 or 2 hours in a busy OPD, you are bound to miss some of these diagnoses by the law of averages. We are all human, we make mistakes. So there are certain leading questions that we need to ask. And there's a simple questionnaire that we had devised during Dr. years back. And this is a questionnaire which can easily administered even by a paramedical personnel, by a first poster, or even a receptionist while the patient is waiting. Just hand these out, let the patient take all these questions. And if you have 2 or more which are positive, then the chances of that patient suffering from some probable cause of pelvic pathology like endometriosis is quite high. Furthermore, there's some specific history that we need to look at as regards pain. Now, we all know that pain is something which is very common. Pain is the hallmark of endometriosis, but there are different types of pain that we need to be able to assess. And the most common kind of pain is cyclical pain. You can also have dysmenorrhea, which occurs in 80% of patients. There is also some amount of chronic pelvic pain, which may develop with long-term patients who have been on treatment for, say, months or months together. And lastly, uterine cramping is something which is ubiquitous by nature. Almost 100% patients give this history of uterine cramping, which, to be very honest, as clinicians, you and I will probably dismiss it as first, second day में सबको होता है, it is absolutely normal. Cramps तो सबको होता है, ये थोड़ा डाइसाइक्लोमिन ले लो, ठीक हो जाएगा, डाइस्पास ले लो, अच्छा हो जाएगा. And that is the way we dismiss our patients out of hand. But if you go carefully into the history, like our teachers used to teach us, listen carefully to the patient. She is telling you what is wrong with her. Don't dismiss her out of it. So let's go to what the guideline and recommendations are. There's an American College guideline, and this guideline was published in 2018. And specifically regarding adolescents, it says that when the patient's history suggests a primary dysmenorrhea, then empirical treatment should be initiated. If there is no relief within 3 to 6 months of such therapy, then by all means investigate for a possible secondary cause and treatment adherence or compliance. Endometriosis is the leading cause of secondary dysmenorrhea in adolescents, and if it is persistent, then you need to be able to treat it with other agents, particularly if all other common conditions which we listed out in that table have been excluded. The common agents which are recommended for therapy, and these are good clinical practice recommendations which are applicable even in India: ibuprofen, naproxen, mefenamic acid, which I just mentioned in the previous slide, and there's something called as celecoxib. I don't think this is widely or easily available in our country. But common NSAIDs are the first line therapy, and after a trial of about 3 months to 6 months has gone past and the patient doesn't have relief of symptoms, that is when you start thinking about endometriosis. Now, commonly, if you read our textbooks, which have been published 5, 10, 20 years, they always say that the gold standard for the diagnosis of endometriosis is laparoscopy. That's all very well. I'm an endoscopic surgeon myself, I do surgery, but then is it pertinent to do a laparoscopy for diagnosis of endometriosis in an adolescent girl before she is even fully grown, so to speak? Laparoscopy in a young girl who has not yet attained age of consent is not only an ethical problem, it's also scientifically something which is not very easy. It can be a challenging surgery because the distance between the cervicasternum to the pubis can be quite short. The abdomen may be flat or may even be scaphoid. The distance from the umbilicus to the abdominal aorta and the bifurcation of the aorta can be very small, and the incidence of complications in such patients can be quite high. So since anyway it is a challenging procedure, it's something which we should not take lightly, and we should think 10 times before we offer it to our patients. Furthermore, in the light of recent evidence, we are now considering that there should be a paradigm shift. We should be thinking of medical management based on whatever history we have, imaging studies which are possible, and diagnostic and operative laparoscopy is something which is no longer considered a primary approach in adolescent endometriosis if diagnosis is the only reason for performing that laparoscopy. If the patient has an endometrioma, he has pain, she has recurrent disease, by all means, of course, those patients do need to be operated. But for most other patients, you will realize that primary laparoscopy is no longer in favor for the adolescent age group. I don't need to inform this August audience what laparoscopy for this looks like or what the staging for the disease is. There are various new staging systems which have come into vogue, especially for diagnosing and prognosticating the fertility potential, but that's beyond the scope of today's discussion. For today's discussion, I think the age-old 1988 AFS classification is good enough, and anyway, we are trying not to do a laparoscopy for these patients. What must be emphasized here is that the appearance in adolescents may not be the same as it is in adults. In fact, the American College Guideline gives examples where you can have these kind of vesicular lesions, and they may be on the peritoneal surfaces, they may be on the retroperitoneum, they may also be in the pouch of Douglas, along the pouch of ureters, on the uterus. The classic appearance is where such lesions can be seen. And these vesicular lesions are more common than the powder burn appearances which we see in adults. There are certain non-invasive methods of diagnosis which are more commonly favored, and these include transfer and ultrasound, which may or may not be possible in the Indian context. You have to be culturally sensitive, and adolescent may not always allow you to transfer ultrasound. It's only a theoretical thing which you write in an exam. In practice, this is almost never possible in India. There's also MRI, which is possible, and there are certain biomarkers which have been identified, which may be helpful. I'll come to those in just a couple of slides. MRI is especially useful if you have lesions which are more than 1 centimeter in diameter. Of course, these are going to be expensive, but then if a patient is not going to allow a transvaginal ultrasound, probably MRI is the only other imaging modality which you can take recourse to with the proper counseling. MRI is especially useful if you have advanced disease or if you have primary disease of the retrovaginal septum. You have deep infiltrating endometriosis, which occurs stage 3, stage 4 disease. MRI is very accurately able to identify these patients, especially where you are not able to put transvaginal. Also, if you have inflammation of the surrounding organs like bladder, bowel, and ureter, again, MRI is to have good sensitivity and specificity. As far as the biomarkers are concerned, you have CA125, which has been around for donkeys' ages, but most guidelines say that CA125 should not be used in isolation. And there are various panels which probably will become available, just like you have an APLA panel, you have a hemophilia panel, which your laboratory person is very familiar with. For endometriosis also, there will be panels which will be available in the coming years with excellent sensitivity and specificity. Two of these I have just mentioned on the slide, CA125 plus CCR type 1 mRNA and MCT1. These are supposed to have more than 90% sensitivity, 80% specificity, and CA125 plus IL-8 and TNF alpha again has very good sensitivity and specificity. It's beyond the scope of today's discussion about these, but I see that over the next 5 to 10 years, especially when you have more of an adolescent crowd which is coming to you, and they want non-invasive tests, and ultrasound is not possible, and of course MRI is too expensive. These kind of biomarkers would probably be very good to screen our patients and also maybe to prognosticate later. As far as the management is concerned, that's what I'm focused on. As we said, the primary approach is to give SAIDs. There is no relief, then investigate further. Once there is a presumptive diagnosis of endometriosis in an adolescent, then you start her on GnRH agonists or the newer alternative diagnosis which is available. Typically, GnRH agonists are not recommended in adolescents because they cause bone loss, and they also are something which can only be prescribed for a very short period of time, 6 cycles, before you start needing add-back therapy. So probably, to all intents and purposes, GnRH agonists as a class of drugs in adolescents is something which we should not be considering. If the patient responds, well and good, you can continue the same agent. If not, then you should be thinking of language. In fact, the ASRM says that medical management is the first choice for 3 distinct classes of patients. One is adolescents, we are talking of today. Second is patients with chronic pelvic pain, and third is patients who have a recurrence disease. We talked about GnRH analogs just a couple of slides ago, and in this table you can see that there are various different modalities which are available for treatment, and this is about endometriosis in general, not specifically for adolescent endometriosis. But I'll draw your attention to this last column, and that is effectiveness of pain rate. Find that all the other agents which are written off in our Spiroc, in other reproductive endocrinology books, be it Shaw, be it Jeffco, COCs, norethistone, LNG-IOS, all of these are mentioned, but probably they are not very efficacious as far as pain relief is concerned. And that's of paramount importance in this age group because you don't want her daily life to be affected. You don't want her to miss school or college. You want her daily life to go on. You don't want her scholastic performance to be impacted. That leaves you with only GnRH agonists and time. GnRH agonists can be prescribed only for 3 to 6 cycles max, we said, and ideally we avoid them in this particular age group. That leaves us only with time. So coming to the all-important question of how long can you give, how much do you give, and finally, or what is important from the patient's point of view, how effective is this treatment? Is it really effective, or is it just being prescribed by us because 10 different company people come and tell us my brand is the best? This is the agent that you should try. Don't try brands from other companies. If you look at the various scientific studies and clinical trials which have been done, you will find that within a period of 20 to 24 weeks, there is significant improvement in diffuse pelvic pain, dysmenorrhea, premenstrual pain, and for adults, dyspareunia as well, which is not very cured. You'll also find that such treatment is endorsed by international guidelines. Specifically, the World Endometriosis Society has recommended diagnosis as an empirical treatment option. How do we monitor and follow up these patients? This is an algorithm which I'll be happy to share with you. Yes, but it's fairly straightforward and quite simple. And this is something which I wanted to spend a couple of minutes talking about, and that's the modified Stellenbosch quality of life. This is something which is not we as OBGYNs are very commonly aware of. But in disciplines like medicine or general surgery, patients who have something like a stoma or somebody who has multiple sclerosis, whatever medical management you offer or the surgery that you do is going to impact the patient's quality of life. And over a period of time, how much of their normal daily activities can be performed and to what degree? That is supposed to be a way of assessing how effective your treatment modality is. And this is something which we talked about also when we did our key practice protocols. And 6 different areas are looked at in this particular questionnaire. And if you find that your score is between 0 to 15, then this patient probably does not have endometriosis. If it's more than 45, then your treatment is not working. If it's between 15 to 45, it probably means that whatever medical management you are offering is working well for this patient at this point in time. And ideally, every 6 months, you should subject the patient to this questionnaire, and then you take it from there. You find that the previous dosage is no longer working well, probably need to up the dosage. If the score has fallen very significantly, then you might reduce the dose. And if you find that it's more than 45, then probably this patient may need a review. She may require surgery. Then you will need to take the call and counsel accordingly. Which brings us very nicely to this last part of the talk, and how do we counsel young girls who have endometriosis, and more importantly, their caregivers, because it's not easy to talk to parents. They are worried, they are concerned. Can this girl get married tomorrow? Will she be able to have children? What is the likelihood that she will have a chronic debilitating disorder? Is she going to land up in a wheelchair? Will she always be bedridden? Is she going to be not productive at all? Can she study further? And so on and so forth. So this is a simple 7-step approach which we devised, and these are freely available on the internet. If you write to me, I'll be happy to share them with you. This is a 7-step counseling guide for patient counseling. This is done in association with one of our academic partners. It's based on an international endometriosis aware group which had met, and this includes psychologists, caregivers, long-term chronic counseling therapists, and so forth. So this is the way that we can counsel these patients and their caregivers as well. There's another set of tools which we devised for patients who have mobility issues, which may or may not be applicable in this particular age. There's also a patient education leaflet which we did. And there are several endometriosis support groups which are available for patients who are well educated, who are literate, who are Google friendly, who are always on their smartphones. These kind of support groups where you have other patients, where you have healthcare professionals who are there looking after these kind of patients, can make a big difference for a chronic debilitating long-term disease. How long can you safely administer these agents? There is data which says that up to 60 months is fine, but these are international figures. These are figures from studies in Japan, where incidentally endometriosis is very common. As of this moment, I don't think there is any specific study regarding long-term treatment with Dynogest in an adolescent age group. As and when that becomes available, obviously we'll update this presentation. But as of today, we don't have any such data regarding long-term use of Dynogest in adolescent girl. As far as the recurrence is concerned, you'll find that the age-old therapies like 2Cs or just taking the patient off therapy gives you recurrence of up to 50%, whereas with Dynogest, it can be as low as just 2% after 5 years, which means it works very well. We've already talked about GNR agonists and skip this section. And the single most important intervention, I will leave you with this one simple final take-home message, is that we need to strike early. We need to identify the disease early, use every possible weapon at our disposal, and arrest the course of the disease. Because as you know, like diabetes, like hypertension, endometriosis doesn't have a clock. As long as there are hormones in the body, tissue is going to grow and it is going to cause inflammation and pain. Therefore, we need to arrest it and keep it in check. There is a lot of study that is going on regarding chronic pelvic pain, multiple different routes and multiple different neurotransmitters that we identified. Beyond the scope of today's talk, to talk about them in detail. Probably someday we can have a plain clinician who treats only specifically pain through various different modalities can come here and talk about it. But I just thought I'd keep that slide in so that all of us are aware that there is a lot of advances which are happening. And fertility preservation is something which all of us should advocate. It's very easy, very widely available. This is one such example, Diana Hayden, former Miss World, and she also had endometriosis. Thanks to frozen oocytes, she was able to have 2 lovely children 8 years after the oocytes. So I'll close with a few simple take-home messages. Endometriosis is a disease for which, unfortunately, we don't have a cure. We can only keep the disease in check. We know that it is associated with impaired ovarian reserve, poor oocyte quality. Any surgery which we advocate, especially in an adolescent girl, should be a curative surgery and all other causes. Then proceed with a presumptive diagnosis of endometriosis. Treat with simple NSAIDs. Patient doesn't respond to 3 to 6 cycles. Go ahead and start medical management with Dynogest. Works well, and there are various different ways in which you can assess, you can follow up the patient, and you can counsel the patient and caregivers, as we want to cover in previous slides. Happiness and freedom begin with a clear understanding with one simple principle. There are some things which are within our control, and this is very important for us as clinicians because we get frustrated seeing the same patient complain with the same things every month or every 3 months. Some things are not under our control. What we can control is our attitude, our approach, and try and make the best of the situation. as we find ourselves. Thank you so much for the patient hearing. Happy to take any questions after the second speaker.
It was a nice, Pratik, very simplified talk, I should say, of an important topic of adolescent endometriosis. And as a clinician of more than 3 decades, and that also in the medical college, with an OPD hanging around about lot mean gynec in adolescent group, your point is taken. History taking is very, very important. And all the gynecologists should know that whenever a patient or an adolescent complains of pain, other than constipation, worm infestation, or whatever GI problems we think of, we should think of this condition also, which is increasing day by day, like polycystic ovarian syndrome. These 2-3 things go hand in hand. Many times you have an adnexal mass on ultrasound and abdominal ultrasound, because he rightly said transvaginal in this age group will not be feasible because of the adolescent age group. The parents counseling is very, very important, because they otherwise go to general practitioners and where they advise sometimes surgery. And I've seen patients coming with some surgery being done, halfway being done, injectables, painkillers being given, and lot of problems with GnRH analogs, like he rightly said, of osteoporosis. And Dynogest we found very good, effective, cost effective also, and less of complications. And your score was really good. That scoring in teaching institutions can be big help. Dissertation or thesis can be given to assess the quality of life and improvement with that specific score and this 7-8 points. And your leaflets were really informative, which can be used by clinicians in the clinics also, and in the medical college setups or in district hospital, so that they know what problems they have. The counseling becomes easy. And endometriosis per se, it is all pain and all dilemmas. So I feel if pain is relieved and counseling being well done, they are much, much happier. And the infertility issues come up later. I thank Pratik very much for the nice lucid talk on endometriosis dilemma in the adolescent age group, which itself is a very precarious region of reproductive age. Thank you very much.
Thank you, Pratik sir. Thank you, Nilesh sir. As I already said, today is a special day. This day has become even bigger and remarkable for Ratlam, because we have 2 ek se badkar ek speakers with us here today, and our beloved chairpersons as the cherry on the cake. About our respected Nilesh sir, I have one thing to share. I think not many people must be knowing this. Sir is a very good artist. Is my screen visible? This sketch has been made by sir.
Yes, visible. Very nice, sir.
I am very happy you have put it on the auspicious day of Navratri. Jai Mata.
It's a beautiful sketch, sir. Now I request Dr. Manisha Maheshwari ma'am to please introduce our next chairperson, Dr. Asha Bakshi ma'am.
I thank Dr. Pratik sir for crisp, informative talk as usual. Now I take the opportunity and my proud privilege to introduce Dr. Asha Bakshi ma'am. Though we all know her very well, she is star of MP on Foxy platform. She is lead consultant, Dr. Asha Bakshi Fertility Center with Motherhood Hospital Indore, Vice President-elect 2022 West Zone Foxy, Organizing Chairperson of AICOG 2022 Indore, Joint Secretary ISAR 2021, long list of credits and honors and achievements, Member Executive Committee AICC RCOG West Zone. Neha, your screen is visible, WhatsApp screen. Dr. Asha is founder chairperson MP IAGE and MP ISAR, founder chairperson of Foxy, chairperson of Foxy Infertility Committee 2017-19, member ICOG Governing Council 2018-21, past president in North.
Now, Manisha, everyone knows. Come on, so, let's talk about Dr. Jaideep.
Yeah, madam, please kindly introduce Dr. Jaideep and call him for his talk.
First of all, I would like to thank Dr. Manisha and Dr. Neha for inviting me and doing such good work at the Foxy platform. And heartiest congratulations that your society has been selected for the award. So
thank you, ma'am.
I'm really proud of you. And today it's really a privilege to introduce none other but Dr. Jaydeep Tag, who is a close friend also and whom I really like. Whenever I see him, I feel that Dhaval is going to grow like him, and I wish he does that. So that's how I feel about Jaydeep. And now about his credentials, he has been, we all know that he has been a very, very sincere Secretary General and has recently completed his term. And he has been past president of Mumbai Ops Gynae Society. And now he is not only a national figure, he is an international figure as well. He has recently been selected as chair International Federation of Obstetrics and Gynecology in the Committee of Safe Abortion. Then he is the Deputy Secretary of AOFOG. Then he is one of the very few ones who have been awarded FRCOG honoris causa in 2020. And he is also past chair Publication and Newsletter Committee AOFOG, past chair Reproductive Endocrinology and Infertility Committee AOFOG, and past chair MTP Committee of FOXY. And about his clinical work, he is a consultant at Ashwini Maternity Surgical Hospital and Center for Endoscopy and IVF. He is co-founder Esperanza Healthcare Private Limited, program director and member of board ProFort IVF, and visiting consultant for IVF at more than many centers, I think all over India. So he's really, and then there are many other things to him, but as a person, I would say that I really like him. He's a thorough Foxian. You ask anything about Foxy and it is on his tips. And he's always willing to help, especially whenever we have asked him for advice for AICOG, he's always there. And besides that, he speaks very well. His knowledge is very good. He's so humble, and he has all the qualities. So, and I'm very sure that he is going to be succeed in the elections. So my best wishes to Jaideep, Dr. Jaydeep Tag, and I invite him to give his talk.
Thank you. Thank you so much, Asha, for that wonderful, such a kind, warm and generous introduction. I really appreciate it. Thank you very, very much for it. Please allow me to share my screen for a minute. So now I hope my slides are seen and I am audible.
No, sir. Your slide is not seen.
So the brochure is the first slide.
Okay, okay. Then it's seen.
Slide seen? Yeah.
Yes, yes.
Okay, all right. So again, thank you very much, Asha. That was such a nice and such a wonderful introduction. I'm overwhelmed. Thank you very much for that. Let me thank Dr. Manisha and Neha for their very kind invitation, and also congratulate the Ratlam Society for doing so well with the Foxy Awards. Many congratulations. I know a lot of work goes into this, and it should really be appreciated. Thank you, Nilesh, for your extremely valid thoughts on the problem of endometriosis. And thank you, Pratik, for a very well thought out presentation. Again, I have known Nilesh, Asha, Neha, Manisha, Pratik since so many years. I think Pratik was with me at the Wadia Hospital many years back. And I remember we had done some studies on fetal medicine along with Dr. Kaizad Damania together. It's always a pleasure to listen to you, Pratik. I am going to speak on best practices in endometriosis, and this is going to be more of an overview of the state of the art as far as endometriosis is concerned. But before I begin, can I request everybody here to please support me as I stand for the presidency of Foxy for this current election year. But before I begin the presentation proper, I think it would be useful to look at some aspects of the literature which surround endometriosis. For example, this is a screenshot of a PubMed search that is done on the topic endometriosis. When you do this, you will find that graph which takes place normally coming on the right-hand side. Why is this graph important? This graph is important because it tells you about the number of studies that are being done on the topic that you are searching for every year. So if you have a graph which starts tall and keeps on coming down, it means that the number of studies that are appearing in the literature on that topic are reducing, which probably means that either all the issues surrounding the topic have been resolved or that topic is not of interest anymore. On the other hand, if you see a graph like this, which starts small and then keeps on increasing and remains at a plateau, it obviously means a lot of articles are being produced on the topic in the literature even currently. And therefore, that topic is extremely relevant, important, and is something which is worth talking about. Endometriosis, as you will see, is something which is certainly worth talking about because, as you will see in the graph, the number of articles that are being published on endometriosis are actually rising every year. So these are the outline of my presentation today, and we'll talk about best practices when it comes to mild endometriosis, endometrioma, severe endometriosis, ERT and endometriosis, and then a little bit about preoperative GnRH, which Pratik also alluded to in his presentation. But before I begin, 3 slides. And I believe these 3 slides are very important because they set the context of how we manage endometriosis today. The first and the most important thing I'd like to say is that endometriosis associated with pain and endometriosis associated with infertility are 2 completely different clinical syndromes. And the reason I say that it is important to triage the patient early is because you will treat a patient of endometriosis with pain very differently compared to a patient who's got endometriosis and infertility. And I will illustrate this as we go along. In the preparation of this presentation, besides the Medline search I showed you earlier, I also looked at several guidelines from across the world. For this particular presentation, I relied on the ASRM, the NICE, and the ESHRE guidelines. But when I did a Medline search, I actually found a very interesting article. This article looked at all the guidelines that were available across the globe from the major organizations and compared all the recommendations which guidelines made. Surprisingly enough, out of the 152 different recommendations made across various international and national guidelines, only 10 recommendations, that is 7% of all the recommendations, were comparable across guidelines. So if you hear different people saying different things about endometriosis, don't be surprised, because even the guidelines don't seem to agree with each other, given the fact that only 7% of the recommendations in guidelines are comparable. If you look at the guidelines qualitatively, you will actually see that the ESHRE guideline was objectively evaluated as the highest quality of guidelines. There is a method of evaluating guidelines. And therefore, what I have done is, after every section of my presentation, I have referred to the ESHRE guidelines to summarize what I have just spoken. Moreover, there is not a single guideline available on endometriosis which followed the standardized guideline development methods called the agree-to methods. So there is a lot wanting in literature, not endometriosis in general, but even on the guidelines. Having laid this context of how we look at the literature on endometriosis and why there are so many different opinions on everything, let's jump into the topic proper. It is now well established that, in fact, the most common forms of endometriosis are not the classical powder burn lesions that we are taught about in UG or PG days. The large majority of endometriotic lesions are actually these atypical endometriotic lesions, and I think it's high time they change the name, because the atypical lesions are certainly much more common than the typical lesions. So you can have peritoneal windows, red flame-like adhesions, etc., etc. And most of the times for grade 1, grade 2 endometriosis, these will be detected as an accidental diagnosis at the time of doing a diagnostic laparoscopy. So if you have grade 1, grade 2 endometriosis, please remember that ovulation suppression cannot be recommended anymore as a standard therapy for endometriosis associated infertility. If the patient has pain, the treatment is to excise. If the patient has infertility, then in this instance, don't just remove the scope and put the patient on danazol or oral contraceptive pill or GnRH. You should manage grade 1, grade 2 endometriosis when diagnosed, whether it be for infertility or for pain, with excision or ablation. Between the two, I would personally prefer to ablate. And the reason I prefer to ablate rather than excise is that excision will lead to the formation of several raw areas in the peritoneum. It will increase the morbidity of the surgery. And moreover, the results between excision and ablation are completely the same. So if you're looking at grade 1, grade 2 endometriosis, between expectant surgical and medical management, you should choose a surgical management. And between excision and ablation, my personal choice is always to ablate rather than excise. But after you have treated grade 1, grade 2 endometriosis this way, what are the results? Quite good. If you look at the data, even if you leave the patient alone for some time, you will see that almost 66% and 94% of patients after this kind of ablation treatment conceive within 3 or 6 months. So if the patient has good fertility potential, and if she just has grade 1, grade 2 endometriosis, and you have treated it surgically, it might be a good idea to leave these patients alone for some time. If, however, after a certain period of time, and we typically leave these patients alone between 3 and 6 months after surgery, things have not worked, then it is better to subject the patient to IUI with ovarian stimulation rather than subjecting them to oral ovulation induction with planned relations. So for grade 1, grade 2 endometriosis, A, ovulation suppression with drugs like danazol or GnRH or OCs is out. The preferred treatment of choice is ablation at the time of the diagnostic laparoscopy. So whenever you put in a scope, be prepared to have at least this kind of intervention. And post-intervention, post-laparoscopy, leave them alone for some time. And if it doesn't work, subject them to IUI 4 to 6 cycles. And if that doesn't work, then you need to move on to IVF. We will now move on to the most commonly discussed topic in endometriosis, and which is endometriomas. And these are the 3 talking points within this section of the presentation. First, treatment when fertility is desired vis-a-vis recurrence. What is the outcome of treatment in the presence of endometrioma, and whether to aspirate or not to aspirate an endometrioma prior to any cycle of assisted reproduction. From this entire presentation, if you remember this one thing, then please remember this. All endometriosis or endometriomas do not need surgery. In fact, I'm sure anybody who has been practicing obstetrics and gynecology for any period of time will have those few patients who had repeated endometrioma excisions and have now come to you with such a low AMH that there is no recourse but to offer them egg donation. And therefore, when you are faced with an endometrioma, you have a choice. You can either do a cystectomy, and again, please remember, I'm talking about infertility. Pain is a completely different story. If this patient has infertility and she has an endometrioma, you have to choose between doing a cystectomy, that means stripping the wall off, or between simply opening the cyst, draining it, and coagulating the active deposits. It is very clear that if you do a cystectomy, your recurrence rate will be lower. If you simply open and fulgurate, your recurrence rate will be higher. But it is also equally clear that every time you strip the ovary of an endometrioma, you will damage ovarian parenchyma and you will reduce ovarian reserve. This is a very interesting study where they went back and looked at the histopathological blocks or slides of patients who had undergone a cystectomy. When they looked at that slide, they found that ovarian parenchyma was found in 40% of the cases of endometrioma cystectomy. When they measured the AMH of patients who had undergone endometrioma stripping surgery, they found that the lowering of AMH is not a transient effect. It lasts for a considerable period of time. And if you look at that study, you will see that the changes in serum AMH levels last for almost 12 months and more after you have done an endometrioma stripping surgery. Therefore, I hope I have been able to convey that although excision may seem to be the treatment of choice vis-a-vis recurrence, it may or should be deferred in infertile patients where the issue of ovarian reserve is of concern. So when you're faced with an endometrioma in a patient of infertility, hesitate to operate first. Try to delay the surgery till as long as she wants children. Operate when she definitely wants children, because once you have operated, you have a limited window of time so that recurrence does not occur and she gets pregnant again. So for infertility, let me reiterate. Patients of infertility with endometriomas who need surgery should be counseled carefully, and rather than excising endometrioma at the risk of a higher recurrence rate, you should simply open, drain, and fulgurate the endometriotic deposits. The question will, of course, then arise, what happens? You're still fulgurating, aren't you? So does that fulguration also reduce ovarian reserve? The answer is no. And the answer has been provided by none other than Jacques Dumas way back in 2001, who looked at patients where there was a cyst wall coagulation, and when the patients underwent IVF, he found that there was no difference in the outcome. There will be times, therefore, when, because of your conservative mindset, you will need to do an IVF in the presence of an endometrioma. And we routinely do this. Our threshold for operating on endometriomas is very high. We generally tend to leave endometriomas alone unless they are in excess of 7 or 8 centimeters. So if perchance you happen to have an endometrioma at the time of doing the pickup, that's perfectly fine. You just work around the endometrioma, try to avoid puncturing the endometrioma as much as possible. But if you do puncture the endometrioma, you really don't need to worry. It will not have any adverse outcome on your IVF cycle. In fact, if you look at this very interesting study, this is a center in Minnesota in the US. We normally do pickups with 10 ml tubes. So we retrieve follicles in 10 ml tubes. They used to do pickups in pre-warmed 60 ml syringes, which contain culture medium. I really don't know why. And inadvertently, in 14 women, they entered endometrioma. So all the endometrioma fluid mixed with the regular oocyte fluid. This did not make any difference to the outcome. But should you actually proactively go ahead and puncture the endometrioma at the time of pickup or before an IVF cycle? The answer is no, because puncturing an endometrioma is actually the largest risk factor for patients to develop ovarian abscess. So to summarize on this issue of IVF in the presence of endometrioma, the presence of endometrioma is not a contraindication for IVF. Work around the endometrioma. If you accidentally puncture it, it's fine, but withdraw the needle. Don't make an attempt to drain the whole endometrioma. It is when you put the needle in for a prolonged period of time and try to drain that the endometrioma bed acts as a focus of infection. If you are operating on endometriomas, remember that you should consider the diagnosis incomplete without a tissue diagnosis. Cancer may lodge in large endometriomas, so you have to be a little careful when you open them. And always remember that despite the advent of laparoscopy, sometimes a laparotomy may be a preferred mode of surgery. It depends on the surgeon. If you think you will do a better job by a laparotomy, by all means do a laparotomy. I remember once Dr. A.G. Tendulkar, a vascular surgeon, speaking on this topic, and he said, opening the abdomen does not equal to loss of virility. Do what you are comfortable in doing rather than trying to adjust to what is the fashion. So when you're looking at endometriomas for infertility, prefer opening rather than excision. Hesitate to operate. All endometriomas do not need surgery. And the presence of an endometrioma, which is less than 7 or 8 centimeters in size, should not be a deterrent for you to do egg pickups. We will now move on to severe endometriosis, grade 3, grade 4. And the first thing I want to say, and this is where the triage of pain and infertility becomes important. If the patient has grade 3, grade 4 endometriosis and pain, by all means be as aggressive as possible at the time of surgery. However, if the presenting symptom is infertility, then quite frankly, there's hardly any evidence to support the fact that extensive surgery will improve fertility. So if that patient does not have pain, even if she has grade 3, grade 4 endometriosis, hesitate please to do a very radical surgery. I see so much on YouTube and all these kind of things, which people posting these very impressive technological feats of surgery where only the ureters and the iliac vessels are seen in patients of endometriosis. But remember that that is in patients who have pain. If there is no pain and the presenting symptom is infertility, then quite clearly there is no decisive benefit of these patients undergoing a very radical surgery, and therefore discretion is most certainly the better part of valor as far as grade 3, grade 4 endometriosis and infertility is concerned. Once you have done the surgery for this patient or you've given a surgery and GnRH, it is always better that in advanced endometriosis you recommend in vitro fertilization as compared to IUI. There has always been a doubt as to whether grade 3, grade 4 endometriosis produces worse results in IVF compared to patients who have a lower grade of endometriosis or perhaps no endometriosis. So this is again an extremely interesting study, very nuanced study. And if you look at this, it says that patients who had endometriosis had lower M2s, more brownish oocytes, significantly worse quality oocytes, however, low fertilization rates. But look at the last slide. No difference with respect to rates of implantation, clinical pregnancy, miscarriage, live birth, and malformation. What does that tell you? That very clearly tells you that the outcome of IVF or infertility treatment in endometriosis doesn't depend on the grade of endometriosis. It more depends on ovarian reserve. And that is why I will again reiterate that if you're looking at an endometrioma in infertility patients, please hesitate to do a stripping surgery, just open and do a very conservative surgery. So if you're looking at severe endometriosis with pain, by all means, do an adhesiolysis, drain and treat endometriomas. If you think you've left a lot of residual endometriosis behind, give GnRH for around 3 months. Second look scopy and adhesiolysis is reserved for the patients of pain. For infertility, it is absolutely not required, and then subject the patients to IVF. And this is exactly what is reiterated in the ESHRE guidelines. If you look at assisted reproduction and endometriosis, you will very clearly see what I have already told you, that whether there is endometriosis or not, you will still get fairly good outcomes in IVF, provided you have a good ovarian reserve. Again, it's not the grade of endometriosis, it is the ovarian reserve, which is actually the deciding factor. How do you perform IVF? Well, it pretty much does not matter. There is a school of thought which seems to think that this is one case of endometriosis as one case scenario where using an agonist protocol is more beneficial. But now there is more than enough data to show that whether you use agonist or you use antagonist, whether you do an IVF in operated or conservatively managed patients, outcomes are absolutely the same. So our protocol for managing severe endometriosis now is we go in, establish the diagnosis, do whatever minimal surgery there is required. We then give GnRH for a period of 3 months. We wait till the patient escapes the effect of GnRH, and once she has escaped the effect of GnRH, we then go ahead and perform an antagonist cycle. Does endometriosis have any effect on pregnancy outcome? The literature is very fragmented on this, and frankly speaking, the amount of literature that is available is also not very significant. There are some stages with some studies which say that yes, it has a significant effect. Other studies which say that it has no effect. Be as it may, I would again reiterate it essentially depends on ovarian reserve rather than your grading of endometriosis. So as a rule of thumb, if you're looking at management of endometriosis for infertility, if it is a mild or atypical grade 1, grade 2 endometriosis, first choice is surgery, preferably by doing an adhesiolysis or an ablation. Then you leave the patient alone for 3 to 6 months. If she doesn't conceive, IUI with gonadotropins, and if that doesn't work, then assisted reproduction. If you're looking at a moderate, severe, that's grade 3, grade 4 endometriosis, surgery if either there is a large endometrioma, but not a radical surgery if there is no pain. Follow that with 3 months of downregulation with depot preparations, and follow that with IVF. A last few slides about preoperative GnRH, and that is, in my view, always a dilemma, because there are some situations where you will need to use preoperative GnRH without establishing the diagnosis. Remember that the gold standard of diagnosis of endometriosis is laparoscopy. I think Pratik reiterated that in, for example, adolescents, you would be hard pressed to convince the patient to undergo a laparoscopy. And the fact is that you can't make a proper diagnosis of endometriosis only on the basis either of symptoms, tumor markers, or ultrasound. So there are certain situations when you can empirically give GnRH, for example, adolescents, patients who have pain and are unable or unwilling to undergo a laparoscopy, and patients with pain who are undergoing a second look laparoscopy. If you're giving empirical GnRH, it's always a good idea to give it for 6 months rather than 3 months, but no longer than 6 months. And of course, now for pain particularly, you could consider the use of Dynogest. So let me end with this quotation from Winston Churchill's The Story of the Malakand Field Force, which says, "I pass from the tossing sea of cause and theory to the firm ground of result and fact." I know that we think we've got a lot of webinars, but I do believe that this period of the pandemic with all its webinars has in fact helped us to go from the tossing sea of cause and theory to the firm ground of result and fact. At the end, let me again reiterate my request to everybody who's here to please support me as I stand for the presidency of FOXY. I've developed a website called isupportjaideep.com. I believe that's the first time anyone in FOXY has developed a website for an election. If you have not visited, please visit it. On the website, you can register your support for me, and I'm delighted to share that almost 3,200 FOXians have already registered their support for me. There is also a Telegram group which you can join. Wherever I give a talk or I'm part of a webinar, I share that on the Telegram group so that people can remain updated, and if they wish to attend, they can attend those webinars. Thank you very much again, Dr. Manisha, Neha, Nilesh, Asha, and Pratik. Thank you very much, Ratlam Society, for inviting me to give this presentation.
Thank you, sir. It was a very nice, very elaborative, very illustrative talk. I think Asha ma'am had to leave.
Yes, she has left. So I will just summarize Sir's talk. Sir, with your permission, shall I?
Yes, please. Yes, please.
Thank you, sir. Sir, thank you for a very informative deliberations and very practical tips you have given on endometriosis, a very difficult topic, and we have different opinions, as you have said, on endometriosis. Large majority of cases, they have atypical variety of presentation and lesions. Grade 1, grade 2 surgical management is preferred, but ovulation suppression is not recommended. And in grade 1 or 2, if there is pain, we excise, though ablation we prefer. And after ablation, if there is infertility, usually the patient, they conceive within 3 to 6 months. And or either after that, we can subject them to IUI with ovulation induction for 4 to 6 cycles. And for endometriosis, sir, you have told that all endometriomas or endometriosis, they do not need surgery. For infertility in endometriosis, we can either go for cystectomy where the recurrence is low, but if we open and fulgurate the lesion, the recurrence is high. But though ovarian reserve is more with open and fulgurating, so we prefer opening and then fulgurating. But the patient counseling is must, and we should look for any cancer which may lurk about in large endometriosis. Sometimes a laparotomy will be better and preferred over laparoscopy. And for grade 3 and 4 endometriomas with pain, we must be aggressive in treatment. But in infertility cases, again, we must hesitate to do radical surgery. And outcome of IVF is not dependent on the grade of or severity of endometriosis. It largely depends on the ovarian reserve. So thank you, sir.
Thank you. You really summarized it very nicely, Dr.
Thank you.
Thank you, Manisha ma'am.
So any more questions? The session is open now. I would like to ask Dr. Pratik, sir, why the incidence in adolescents, is there something increasing during increasing?
So traditionally, there have been several theories, ma'am, as to the causation of endometriosis. We've studied that in our undergraduate as well as postgraduate years, Sampson's theory and so on and so forth. But what is overwhelmingly a clear-cut fact is that people who live in coastal regions, those who consume a lot of rice, maybe those who are exposed to environmental pollutants of certain kinds, which have not yet been identified. These are all the common theories that are spoken of for the increasing trend over the past 20 to 25 years. Also, we have to note that these days we have a lot of plastic, microplastics, environmental pollutants that are there all around us. And these are also some of the factors which have been highlighted for the increasing trend in diseases like endometriosis. Of course, now patients will present earlier. Most of them will have a low pain threshold. All these things we are aware of. But besides the usual culprits, the usual suspects, so to speak, there is a lot of environmental pollution and certain factors which have resulted in increased trend, especially in adults.
How much time we can give Dynogest in adolescents? Maximum time period?
So as I said, the theory is that you can give it for up to 5 years, but all these studies come from Japan. And Japan is incidentally the country where Dynogest was first licensed for use way back in 1995. Most of these studies are done in adult patients, because I don't know any ethics committee which will approve of any medication, leave alone Dynogest, specifically in an adolescent age group, unfortunately. So there are no studies specifically in the adolescent population, to my knowledge. But if we extrapolate the evidence from adults, you can give it for up to 60 months. Up to 5 years is absolutely fine.
Okay. Thank you, sir.
Sir, Dr. Sanjana Mahesh wants to know, what is the role of Mirena IUCD in severe endometriosis?
So Mirena is one of the medications which has been postulated, and I think I briefly flashed a slide where I compared all the different theoretical medical managements, which included GnRH agonists, OC pills, which we have read of from our 1990s, Spiroff and Insler, and LNG-IUS or Mirena is one of the other alternatives which has been proposed. Now, there are Western studies which say that Mirena gives excellent pain relief. It helps in curing dyspareunia as well as dysmenorrhea to a very large extent. And there are also certain studies where they have used Mirena in adolescents and nulliparous women. And the efficacy as far as pain relief is concerned is quite high. Whether that is something which will be applicable to our adolescent population with despite good counseling and our best, having the patient's best interests at heart, whether that will really take off is something which I doubt. It's something which is there on the table. You can offer it to the patient. You can show them that there are studies which show that this is quite effective. But I think most patients would view it with a lot of skepticism, to be very honest.
So I'll just add to that, Pratik.
Yes, sir.
The first time I heard about Mirena and its use in endometriosis was when I had gone to the AOFOG conference in New Zealand, and Professor Ian Fraser was talking about dysmenorrhea. And he presented this extremely interesting work where they correlated endometriosis patients with pain versus patients with no pain and did endometrial biopsies. In patients who had pain, they found that there were neuroreceptors in the basal layer of the endometrium. And when you put a Mirena, what happens is that these neuroreceptors or the pain receptors in the basal layer actually get atrophied. And that is how the Mirena works. It doesn't work by actually reducing the endometriosis. So it works actually. So for example, if you put an Mirena for a patient of grade 3, grade 4 endometriosis with pain, it won't make that endometriosis grade 1, grade 2. What it will do is it will atrophy the neuroreceptors which are present in the basal layer, and therefore when the patient gets a period, she will not get pain. So I just thought I'll add that. And it was a very interesting study. In fact, at that time, they had proposed that this could be an excellent biomarker for endometriosis. But of course, it would only be applicable for patients who have pain and endometriosis. So in patients where you had severe pelvic pain, they said do an endometrial biopsy, subject them to silver staining. And that silver staining, if it showed these pain receptors, then you could make an indirect diagnosis of endometriosis. I just thought I'll add that because that was a very interesting fact which has stayed with me for a while.
Any more questions, Dr. Neha?
No, ma'am, there are no more questions in chat box. Asking question to sir is also like a matter of courage, no? Not everyone can dare to do that.
Not at all, not at all.
But I think he's the easiest person to approach.
Yes,
And
ma'am.
he always replies.
Thank you, madam.
Sir is very humble, very good natured. Both the sirs, like Pratik sir, Jaideep sir.
Yes, definitely.
I keep bothering them by my chats and by WhatsApp.
Anytime.
Jaideep sir, I don't know whether you remember or not. We met in Raipur in Happy
Yes.
Gynecon.
Yes, very much.
So I think we can conclude the session. There are a lot of compliments in the chat box.
Yes.
The questions are done, I guess. Saying thank you to all the dignitaries today is like जैसे सूरज को दिया दिखाना. Our heartfelt gratitude to Dr. Asha Bakshi ma'am, Dr. Nilesh Dalal sir, our learned speakers, Dr. Pratik Tambe sir and Dr. Jaideep sir, for sparing their time and sharing all the knowledge. All the best, Jaideep sir, for Foxy elections.
Thank you.
You're already a winner, sir.
Thank you very much.
Heartiest thanks to all the members of Foxy for attending and making this webinar a success. Thanks to ICOG for granting us 1 ICOG credit point for this webinar. And special thanks to Team Pharmacents for organizing the event. Thank you, everyone.
Thank you, sir.
Bye. Good night.
Thank you. Good night, sir. Thank you, Tambe sir.